Hello everyone, I am Dr. Lahari here, and today I will be talking to you about pulp and periapical diseases. This is the second part of the lecture, and we will be dealing with the sequelae of pulpitis and some correlation of clinical and radiographic findings as well. The learning outcomes that were outlined were to explain the clinical features of pulpal diseases, of periapical diseases, the sequelae of pulpitis, as well as differentiating periapical lesions based on their history, clinical presentation, and histopathology. Pulpitis, the etiology, as discussed in the previous lecture, is due to either bacterial causes leading to dental caries, mechanical, also called as physical causes due to trauma, attrition, abrasion, or erosion of the teeth, chemical causes due to either cements or any other restorative material which can have caustic effect on the pulp, thermal causes due to excessive heat or cold exposure to the pulp, and iatrogenic causes due to accidental exposure during cavity preparation, for example. Now, this was the chart which was given to you for sequelae of pulpitis. The term sequelae means that what happens next after the tooth gets inflamed or after the pulp gets inflamed. So, we will be elaborating more about this algorithm further in this lecture. I just want you to remember that pulpitis leads to apical periodontitis, which could further lead to an abscess, granuloma, or cysts, which are interchangeable, and worsening of this periapical situation can lead to osteomyelitis, periostitis, or soft tissue cellulitis or abscess as well. Let's look at each and every clinical scenario. I have tried to correlate the chief complaint of the patient with what we are seeing clinically, what the radiograph would look like, and how we arrive at a diagnosis and how the treatment would be given. Now, let's look at the scenario number one, where patient complains of pain that is mild to moderate and intermittent, that means on and off pain. Patient also complains of pain on application of stimulus only. That means, for example, the patient tells you that I have pain while eating something cold. For example, I have pain when I'm having cold drinks or ice cream. And the pain subsides immediately after removal of stimulus. So this gives you a very clear idea that perhaps only the dentine is involved and pulp per se is not yet involved. The clinical features is generally a deep caries with a score of ICIDA 0.5 or large metallic restorations. Pulp is not involved and the tooth is non-tender on percussion. On a radiograph, you can clearly see that there is caries, for example, in this case, and it is not yet involving the pulp, but it is close to the pulp. So our diagnosis would be reversible pulpitis. Now, based on whether the patient has symptoms or no, we would call it either symptomatic reversible pulpitis or asymptomatic reversible pulpitis. And the treatment plan for such a situation would be restoration. A simple restoration. If it is very close to the pulp, your caries is very close to the pulp, then you might want to go in for deep caries management, also called as indirect pulp capping. Let's look at the second situation. Patient complains of severe continuous pain. Pain persists even after removal of stimulus that evoked it. In the previous situation, the pain was intermittent, and after the stimulus was removed, the patient did not have pain. But let us look at this situation where the patient has persistent pain, continuous in nature, which persists even after removal of stimulus. The pain aggravates on application of stimulus and in lying down position. That patient will typically tell you that, doctor, I have had a sleepless night the previous night. I haven't been able to sleep very well because of the pain. So this particular symptom is called as postural variation. And the patient may not be able to localize the offending tooth because of the severity of the pain. Clinical features would be you would see a tooth with deep pulpal involvement, generally in ICIDA 06. You could even see secondary caries involving pulp, fractured or discolored teeth, deep lesions of abrasion, attrition, erosion involving the pulp. The case clinically, there would be no swelling or discharge. The tooth is still non-tender to percussion, and early response to vitality tests would be seen. So on the radiograph, you would be able to see a very deep caries clearly involving the pulp, or in situations where there is a fracture, you would be able to see that the fracture line is involving the pulp. Now, this situation, the diagnosis would be called as irreversible pulpitis. Again, it could be symptomatic if your patient has come to you with a short duration or acute symptoms and severe pain, or it could be asymptomatic in irreversible pulpitis, in which the pain has been long standing, the caries is still involving the pulp, but the patient is not having pain due to a high pain threshold. So these are typically the chronic cases. The treatment in either which way would be an RCT. Now, in situations where you cannot perform a root canal treatment, extraction would be the choice of treatment. Let's look at situation number 3. Now, pulpitis can also manifest as a hyperplastic pulpitis or a pulp polyp, generally seen in large carious lesions in young adults or in children, and you would see a pinkish red globule of pulp tissue which fills the entire carious cavity. Generally, the chief complaint would be mild or no pain, and which is common in deciduous molars and permanent first molars, large open dental carious lesion like I just described. The hyperplastic pulp is insensitive to manipulation, but it bleeds on probing. In generally, the tooth is non-tender to percussion, and early response to vitality test is seen. The diagnosis is called as hyperplastic pulpitis, and again, this sort of a situation, the treatment would be root canaling or extraction. On radiograph, you would see similar findings of a wide area of tooth involvement with pulp involvement, and the apex is generally normal. Moving on, pulp necrosis. This terminology also is a pulpitis in which the entire pulp has undergone necrosis and generally the tooth is discolored. The discoloration can range from shades of brown to black depending upon the duration of the discoloration. The discoloration generally happens because of the dentinal tubules getting discolored due to necrosis of the pulp and the components of the hemosiderin contributing to staining of the dentinal tubules. Moving on, let's move on to apical periodontitis. Generally, when the caries progresses from pulpitis to apical periodontitis, the patient may complain of pain which is moderate to severe, could be continuous and throbbing as well. The pain may aggravate on application of stimulus such as chewing, generally because the apical fibers are inflamed, and on chewing the tooth tends to move in the socket, and hence typically the patient complains of pain while chewing or biting with those teeth. There may be past history of pain or may not be present at all. No past history of swelling or fever. The pain may radiate to the adjacent structures and there's definitely difficulty on mastication. The clinical features would be no regional lymphadenitis, there is pulpal involvement clearly, there is no swelling or discharge, no sinus opening, and the tooth is tender on percussion. So this is the difference between the previous stage of reversible and irreversible pulpitis, where the teeth were non-tender on percussion, whereas in apical periodontitis, clearly the teeth are tender on percussion. There is no response or delayed response for vitality tests, generally in asymptomatic apical periodontitis. So the radiographic features would show you caries or fracture involving the pulp, and in cases of long-standing apical periodontitis, you would be able to see widening of the PDL space at the apical foramen region. So this is classical radiographic features of long-standing apical periodontitis. So the diagnosis would be given as apical or periapical periodontitis, which is generally called as symptomatic apical periodontitis when it is short duration or acute in nature and the patient is having tenderness on percussion, on examination. Or asymptomatic apical periodontitis, when it is longer duration, and tenderness may or may not be present, and on radiograph definitely there is widening of PDL space seen. The treatment again would be root canal treatment or extraction of the tooth depending on the case. Moving on, the patient now has come to a phase of pain which is moderate, severe, or continuous, could be throbbing or radiating. The pain could be short duration, less than a week, if we are talking about acute periapical abscess. Generally, the relief from pain is only on taking medication. It may aggravate on stimulus and chewing, and there is past history of pain which may or may not be present, and there's no past history of swelling or past discharge. So that's when you call it as an acute abscess, because this is the first time that the patient is experiencing the abscess. Generally, the patient might also have systemic symptoms of fever, chills, and may complain to you that he doesn't feel very well. On clinical features, there could be regional lymph nodes enlarged, which could be palpable and soft and tender. The pulp involvement is visibly seen. Clinically, may not have any swelling or mild swelling only in the periapical or the attached gingiva region. There is no sinus opening present, and the vestibule may be tender, vestibule which is adjacent to the tooth of interest, and definitely the tooth would be tender to percussion. On radiograph, you may or may not see widening of the periodontal ligament space. There is evidence of breakdown of lamina dura. Again, depends on how long the apical abscess has been in the oral cavity, and generally there is no periapical radiolucency formed yet, because we're talking about an acute case, and generally acute features don't show up very early on the radiograph. You would require at least 5 to 7 days to see visible changes on the radiograph after you have the tooth has been painful and there is an abscess existing. So the diagnosis would be an acute periapical abscess. Now, if there is a visible swelling in the cheek, then you would want to extend the terminology to an acute dento-alveolar abscess. Essentially, a periapical abscess and dento-alveolar abscess are the same. It's just that the extent of involvement in a dento-alveolar abscess is larger. So the treatment plan would be an emergency access opening, and followed by root canal treatment or an extraction. The patient will require painkillers to subside the pain. This is how the dentoalveolar abscess is an example which I have picked out from for you. And if there is a visible swelling, you might want to add in antibiotics, and incision and drainage is recommended as a local measure in order to ease the pain for the patient and for fast relief as well as early healing. Moving on, when the pain is not present or absent or mild, and there is a history of abscess, we would generally call it as a chronic periapical abscess. This is a long duration situation, which is generally more than a week. Patient could be totally asymptomatic, and past history of swelling may be there. In some cases, patient may not have realized that there was a swelling, or there could have been symptoms and patient could have ignored it. There could be past history of past discharge as well. On clinical features, you are seeing deep carious lesion with pulpal involvement. There may be regional lymph nodes which are enlarged and palpable, firm and non-tender. So this is different from the acute abscess, where generally the lymph nodes are soft and tender, whereas in chronic cases they're generally firm and non-tender. Patient will not complain to you about fevers or chills, and he may be totally asymptomatic. Sinus openings could be present. That means the pus has found its way to come out of the bone and vent out into the oral cavity through a sinus tract. Generally, the sinus tracts are present on the buccal attached gingiva, rarely on the lingual surface. They can be seen as well. The tooth may or may not be tender to percussion. Just in case there's a sinus, generally teeth are non-tender because there is no pressure build-up and the pus has found its way out. Tooth would have no response or delayed response for vitality tests. On the radiograph features, you would see that there's loss of periodontal ligament space and breakdown of lamina dura at the apex of the tooth, and there's a diffuse periapical radiolucency of varying size. The radiolucency has happened because of breakdown of bone and osteoclastic activity, and generally, this is the typical feature which you're seeing on the radiograph here of a chronic periapical abscess. The treatment plan would be root canal treatment or extraction, again, depending on the case. And after the root canal treatment, this periapical area would generally heal. It might take up to 6 months for normal bone to fill up the defect seen in which was left behind because of the periapical pathology. So this is just a clinical example of an abscess which is where you can see that there is pus which is accumulated very close to the attached gingiva and it is just about to drain. Parolis is the term given to granulation tissue around a draining sinus opening. This happens multiple times when the sinus has drained and there the tissue around which is inflamed due to reaction of the tissue around it. It forms granulation tissue and appears like a swelling which remains in the oral cavity till the tooth is treated or the etiology is taken care of. There's another terminology which I would want you to pay attention to, which is called as acute exacerbation of a chronic periapical abscess. It was also called as a phoenix abscess. It's just interesting to understand that phoenix is a bird that raises from the ashes. So keeping that in mind, this abscess has the same clinical features as acute periapical abscess or an acute dentoalveolar abscess. That means the patient comes to you with acute symptoms but has had a past history of swelling or pain, or there is a sinus opening on clinical examination, or both of them. So that means it's very important when you're taking history of the patient to ask them if they've had previous episodes of swelling. So when you are noting down the HOPI of pain, the old cards the mnemonic that you follow, the S stands for swelling. Now what we mean by swelling is either history of swelling or presence of current swelling. Which you would want to note down. So if the patient tells you in your history itself that yes, I've had a swelling with this tooth in the gum and since then it has subsided and I've done nothing about it and I've got pain again and swelling again today, then you already have your diagnosis in front of you. It's an acute exacerbation of a chronic periapical abscess. Periapical granuloma and periapical cysts. Now, the history generally, patient is generally not complaining of pain. They may be totally asymptomatic or may have tenderness on biting hard food. Generally, a granuloma and a small periapical cyst is something that you would not be able to recognize while looking at the patient clinically, and you would only be able to tell that there is a periapical lesion based on the radiograph. There is definite pulpal involvement. Patient could be totally asymptomatic and the tooth may not be tender on percussion, and there may be no responses for vitality tests simply because the tooth is already non-vital. So periapical cysts, if they are larger in size, they can cause expansion of cortical plates of bone, because of which the patient would tell you on examination would have a hard swelling in the jaw, which could be chronic in nature. That's but obvious because cyst cannot happen overnight. It takes time for cyst formation to take place in the bone. Whereas on the other hand, an abscess is generally acute and can happen overnight and would be a soft tissue swelling, whereas a cyst would be generally a bony hard tissue swelling. So that is one important difference that you need to keep in mind when you're diagnosing. So these are some radiographic appearance to make you understand that generally a granuloma is very common periapical pathology, well defined, small radiolucency, less than 0.5 centimeters in size, attached to the apical region or the root of the tooth. Generally the lamina dura and perial space are lost and there is a soft tissue granulation tissue, but that's why it's called as a granuloma. On the other hand, a periapical cyst, very similar in appearance but could be larger. They could be very large cysts which are more than 2 to 3 cm in size as well, in which case all the teeth involved must be checked for vitality and must undergo root canal treatment if non-vital, and probably a large lesion like this might end up going for episectomy, which you will learn about a little later on in your endodontics topics. As the pulp and the periapex react to periapical infections as a part of the inflammation process. The root apex in the alveolar bone could show changes. Now, as a reaction to inflammation, generally the alveolar bone reacts by bone formation, which is denoted by osteoblastic activity, or bone resorption, which is denoted by osteoclastic activity. So when there is bone resorption, you would see more radiolucency, which indicates a rarefying osteitis, inflammation of the bone, and rarefication of the bone, which means that there is more radiolucency. On the other hand, when there is osteoblastic activity, that means the host response is better. Then there is condensing osteitis, also called as sclerosing osteitis, due to increased amount of osteoblastic activity. So there is a balance in the bone between the osteoblastic and osteoclastic activity. And these both terms, rarefying osteitis as well as condensing osteitis, are radiology terminology. And clinically, the manifestation would either be as apical periodontitis or an abscess based on the amount of based on the clinical findings. So let me just remind you about the sequelae of pulpitis again. We've looked at 1 and 2, which is reversible and irreversible pulpitis, which leads to apical periodontitis. I have also included hyperplastic pulpitis and pulp necrosis, which we've discussed, which are all types of pulpitis. Pulpitis can be symptomatic or asymptomatic. When you're talking about apical periodontitis, that means the pulpitis, if not treated, leads to apical infection, could again be symptomatic or asymptomatic. When apical periodontitis is not treated and it progresses further, it could go on to an abscess, which could be acute, chronic, or acute exacerbation of chronic abscess. And then there could be variations as a periapical granuloma, cyst, and moving on, it further spreads to osteomyelitis, periostitis, cellulitis, or an abscess. So let's look at the remaining terminology in the next coming slides. When there is odontogenic infection, spread of infection can happen in any of the directions that are shown here in this picture. In the maxilla, the infection can spread through the soft tissue or the hard tissue towards the buccal surface of the bone or into the maxillary sinus or the nasal passage. In the mandible, similarly, it could spread through the soft tissue or the hard tissue. When there is spread of infection to the bone, the inflammation of the bone and bone marrow, when it happens, the infection is called as osteomyelitis. Discussion regarding types of osteomyelitis and management of osteomyelitis is beyond the scope of this lecture, so we will leave it to another lecture to discuss it in detail. Other than osteomyelitis, infection can also spread through the soft tissue spaces and either cause a space infection or cellulitis. For example, the picture on the right is showing you a firm, brawny or reddish swelling and with shiny surface of the skin and with an orange peel appearance, and this is called as cellulitis. On the other hand, a space infection is a lot more softer and the swelling is generally tender. In both cases, the swelling can be tender. So, and when there is soft tissue spaces in the head and neck region involved, in the maxillofacial area especially, it's called as a space infection. Again, more of this would be dealt with in when we are dealing with spread of infection further on in a different topic. I would like to introduce you to the term endo-perio lesion, also called as pulpo-periodontal lesion. When there is caries in the tooth, a primary dental involvement in the tooth, and there is a periapical pathology, as well as there is a pocket and periodontal involvement, when these two inflammations meet together and lead to an abscess, it's called as an endo-perio abscess. So treatment of this sort of a case would involve both root canal treatment as well as managing the periodontal aspect of the either by root planing or managing the furcation area with scaling and other periodontal methods of treatment. On the other hand, when there is a primary periodontal involvement and infection and bacteria from the periodontal pocket reach the periapex of the tooth and enter the periapex via the retrograde infection and infect the pulp and lead to non-vitality of the tooth. The process is called as a perioendo abscess. So the terminology to understand here is a retrograde infection, and the pathogens are actually anaerobic bacteria which are coming through the pocket and enter the apical foramen and reach the pulp. So in this case, you would not see a caries, but definitely the tooth could become non-vital. So the source of infection is originating from the pocket region of the periodontium. So that brings me to the end of this chapter. I have derived some pictures from some important sources and some information from sources which I would like you to go through. So thank you for paying attention to me. If you do have any doubts, please get back to me. We can discuss further in the clinical sessions.